Dr. Catherine Gold from University of California, San Diego is going to do the rapid fire.
Okay. Let's see if I can get my slides up. So I was asked to go over some of the ASCO abstracts. It was a bit of a slow year for lung cancer at ASCO, and I think that's because our standard of care for almost everyone with lung cancer has changed in the past 3 years. So the trials that are being reported are the ones that were designed comparing it to the old standard of care, so it's hard to know how to fit things in to our current standard of care. But I'll talk about a few abstracts, disclosures. So first one that I'll be talking about is the RELAY trial that got mentioned briefly in Dr. Ackerley's talk. This is a randomized phase 3 trial of erlotinib plus or minus ramucirumab in the first-line setting in EGFR mutant non-small cell lung cancer. So which of the following is true? A, adding ramucirumab significantly improves progression-free survival. B, adding ramucirumab improves response rate. C, adding ramucirumab improves overall survival. Or D, all of the above. I know someone's still awake out there. 2 people. Anyone else? Okay. So the correct answer is A. Adding ramucirumab improved progression-free survival, but did not improve response rate, did not improve overall survival. Sorry, I am not seeing what's shown up there, so I apologize if I keep looking backwards. But here's the study design of the RELAY trial. It was a well-designed, pretty straightforward study, a phase 3 trial, where patients with EGFR mutant non-small cell lung cancer who had never received treatment before were randomized to either erlotinib or erlotinib plus ramucirumab. Primary endpoint of this trial was designed to be progression-free survival. Secondary endpoints were overall survival and response rate. It did meet its primary endpoint of progression-free survival with about a 7-month improvement in median progression-free survival, but did not meet its primary, it did not have differences in overall survival or in response rate. The overall survival was not yet mature, but from the data that they presented, it didn't even look like there was really a trend towards difference at this time. So another trial with EGFR mutant non-small cell lung cancer was gefitinib versus carboplatin pemetrexed gefitinib. And which of the following is significantly increased with the chemotherapy regimen versus gefitinib alone? Response rate is A, progression-free survival B, 18-month overall survival C, toxicity D, or E, all of the above. Okay, this time it was all of the above. So this regimen did improve response rate when adding chemotherapy, progression-free survival, overall survival, but at the cost of increased toxicity. And again, here was the clinical trial design, randomized trial, not placebo-controlled, obviously, because you can't really placebo-control getting chemotherapy. It was a single institution trial. This was done in India at Tata Memorial Hospital, so I think that accounts for some of the results that we're seeing as far as very low rates of second-line therapy. But here were the trial results. On the left, we have progression-free survival. On the right, we have the overall survival, and you can see that those are some pretty impressive-looking curves. The response rate was improved from 62 to 75% with chemotherapy. But one of the problems with this trial that makes it kind of tough to interpret is very few patients receive second-line therapy. And I think in the United States, almost all of these patients would have gone on to second-line therapy, and specifically less than 15% received osimertinib after progressing on this trial. Understandably, when you add chemotherapy, you add a lot of toxicity on, where the vast majority of patients had grade 3 and 4 toxicity when they received chemotherapy, many more than would on erlotinib alone. So of these studies, do either of them change my standard of practice? And honestly, not really. They're both compared to old therapy, to erlotinib or gefitinib. They're not compared to our current standard of care, which has been osimertinib for a few years now. So I agree with what Dr. Ackerley mentioned, that the chemo plus EGFR TKI is very interesting data, but I do think it needs to be repeated with osimertinib before I start adding that to my practice. So next up is another phase 3 trial that was presented at ASCO, and this was a Japanese study looking at vinorelbine cisplatin versus pemetrexed cisplatin in resected stage 2 and 3A non-squamous lung cancer. So this trial showed which of the following. A, cisplatin pemetrexed improves overall survival compared to cisplatin vinorelbine as adjuvant therapy. B, cis-vinorelbine improves overall survival compared to cisplatin pemetrexed. Or C, they have comparable overall survival between the arms. Okay, we've got, votes are pretty well divided here. So the correct answer for this one is C. It actually showed that the overall survival was equivalent between those two regimens. So study design, patients that had to have completely resected non-squamous, non-small cell lung cancer, had to have a good performance status, stage 2 to 3A based on AJCC 7, so a little bit different than the AJCC 8 that we're using right now. Most of these patients had node-positive disease. Randomized between cisplatin vinorelbine and cisplatin pemetrexed at standard doses. And what they found was that the recurrence-free survival curves looked pretty much the same between the arms, with a pretty decent median overall median follow-up of 45 months. Overall survival was also equivalent between the arms. As most of us that have used both of these regimens were expected to see, the tolerability was better with cisplatin pemetrexed. 87% of people were able to complete the four cycles of therapy versus 75% with the vinorelbine-containing regimen. There were less hematologic toxicities. So the question is always, how do I use this? And to be honest, I was already using cisplatin in the adjuvant setting, but it's nice to have data kind of confirming that approach. Before, we'd been extrapolating what we knew from the metastatic setting into the adjuvant setting, but now we have this randomized data showing us that this is as good as the more well-validated regimen. So the NCCN has reflected this for a while now and does list cisplatin pemetrexed as an option for non-squamous.
We're NCCN members. Yeah, so we're just going like a high five.
Okay.
When you are.
Yes. I sit on the small cell section, which we have much shorter meetings than I'm presuming the non-small cell section does. We actually don't even meet in person because, as you mentioned, small cell is where, dreams and careers go to die, unfortunately. But I did feel like we should at least mention a few of the small cell trials that were presented at ASCO this year. 2 trials were presented that I thought worthy of at least bringing up, and that was lurbinectedin and trilaciclib. And the trials presented at ASCO showed which of the following. A, trilaciclib is a CDK4/6 inhibitor that improves response rates when combined with topotecan. B, trilaciclib is a CDK4/6 inhibitor that decreases the risk of hematologic toxicity when administered with topotecan. C, lurbinectedin has a response rate greater than 30% in previously treated small cell lung cancer in a single-arm trial. D, lurbinectedin was, sorry, I've been practicing saying that and I still get it wrong, was shown to be tolerable in combination with carboplatin and etoposide for frontline treatment of extensive stage small cell. Or E, B and C. Okay, so the correct answer here is actually E, B and C. So I think the fact that an oral presentation was made based on a compound that just reduces hematologic toxicity without improving any outcomes shows how exciting a year it was in lung cancer at ASCO. So trilaciclib does decrease the risk of hematologic toxicity, and lurbinectedin has a response rate a little higher than 30% in previously treated small cell. So here's a trial design for trilaciclib, and I do apologize. I don't know that as far as the technical people, the slides aren't showing up here. But what it took is people that were receiving topotecan for second-line therapy of small cell, and they were randomized to either topotecan or trilaciclib, and the primary endpoint was duration of severe neutropenia in cycle 1 and occurrence of severe neutropenia. And they also, they did not include as a key secondary endpoint response rate and survival, but they did report that. So what they found was that the duration of severe neutropenia was a bit shorter for patients that got the study drug versus patients that did not. However, that did not result in any improvement in progression-free survival or overall survival or response rates. Something that I think may be more interesting in the future, because I'm an eternal optimist and all the negative trials in small cell have not yet beaten me down, but this is a lurbinectedin study design. It was a single-arm phase 2 trial looking at patients with platinum refractory small cell lung cancer. They did allow patients who had progressed on immunotherapy, although that was only a minority of patients in the trial. And their primary endpoint was response rate. And here were their waterfall plots, which looks pretty good. About 30, I believe it was 37% of patients had a partial response. The median progression-free survival was 3.9 months. Progression-free survival at 6 months was 33%. And median overall survival was 9.3 months in a pretreated population. So not bad compared to historical controls, but we'll see where this goes in phase 3. So do these studies change my practice? No, not yet. I have trouble justifying adding something like trilaciclib on to decrease hematologic toxicity if it doesn't improve outcome. It seems like an expensive way to do that with a fair number of side effects, so hard to imagine how that's going to fit into practice. With lurbinectedin, they do have a phase 3 trial in combination with adriamycin, where they're comparing that to investigators' choice of topotecan versus CAV with a primary endpoint of overall survival. It's completed accrual, and since trials in previously treated small cell don't take that long to reach their endpoint, I expect we'll see some results of that pretty soon, and maybe we'll finally have a positive phase 3, I hope, but we shall see. And that was very rapid fire, but thank you.
All right, thank you, Dr. Gold. I think we do have time for questions from the audience. If anybody wants to ask any questions to the panel, please. Go ahead.
So how do you explain the lower neutropenia with adding a CDK4/6 in breast? It increases it, so it kind of doesn't make any sense.
Yeah, so it's based on the fact that almost all small cell has lost RB expression. So, huh? There we go. So the idea is that the trilaciclib, to be quite honest, this is far from my area of scientific expertise, but it does not affect the tumor at all, and it's thought to have a protective effect on the white blood cells, but it doesn't make a whole lot of sense to me, so I apologize. I don't know the science behind it all that well. I don't know if either of you can do better than me.
Great question when no one knows the answer.
Yes, sorry.
Thank you. Can I ask, please, a practical question now? Now that we start to see this patient with unresectable metastatic non-small cell lung cancer that has been on immunotherapy as a second line for a while now, that 25-30% survival, from the practical point of view, do you consider ceasing immunotherapy like melanoma data, like after 1 year, and you withhold immunotherapy of these patients, and the same with the Pacific study with durvalumab, after 1 year on a stage 3 post-radiation, you cease or you continue the durvalumab in the real world?
We may have 3 different responses, so why don't we go 1, 2, 3 and see what we do here.
So durvalumab, I'm stopping after a year for stage 3. I feel like there's no data in continuing it. I've only gotten a few people through a year, and they're so far doing okay after completion. In the metastatic setting, if people are doing well, I've been continuing it basically indefinitely, but it's a risk-benefit discussion. At 2 years, I sit down with the patient and I say, we don't know what this does or not. If you want to take a break, I think that's reasonable. Most of them opt to continue it, and so far insurance companies have not been giving me blowback.
Yeah, one thing that is always in your favor is that insurance companies are profoundly stupid, so that helps.
That's always in your favor.
Right. Well, when you want to do something like this, I want to continue indefinitely. Like, oh, okay. So my answer is almost a complete mirror of what she said. In the curative setting, I think it's hard to make a case to go beyond a year, because remember, before this, we still cure patients with chemoimmunotherapy. And you want to make sure that you're not giving 2, 3, 4 years of durvalumab with someone that was actually cured with your platinum radiation therapy strategy. And they will be at 20 to 25% of the patients that are ultimately cured in this setting. Metastatic setting, exactly the same thing. I start having the discussion around 2 years. I don't force it, but I would say that the vast majority of patients that are tolerating well will turn to you and say, "Are you crazy? You know, I'm doing so well, I'm not having any toxicity, we're not changing anything."
And I will complete, well, so no right answer. If you're in a curative situation, as mentioned already, I stop at a year. I mean, they may well be cured. Why do I have to increase cost? I stop at a year. In a metastatic setting, I've been stopping around a year. And the issues for me are, there's a bunch of anecdotes where I have patients referred to me who got 2 crappy doses or something like that and show up in my clinic 6 months later and they're doing fine. I've actually watched them for quite a while. Second, there's a BMS 153 study. And the 153 study treated lots of patients. At 1 year, they randomized to continue therapy versus not continue therapy. And that study showed no difference in overall survival. And I've got, I don't know, 3 patients, I think, on that study who were randomized to no more therapy. And they're 3 years out now with no further therapy. And so the study data randomized says you don't necessarily have to go beyond a year, although the relapses were somewhat more frequent in the arm that stopped early, but not enough to make a difference in survival.
Yeah, I think that Wally said one thing that's really important. If someone stops because of toxicity, I would not restart it. I wouldn't have any discussion regarding restarting unless there is clear evidence of disease progression. And the reason for that is that, you know, I think we all have in our practices people that have stopped it because of toxicity and the disease has not manifested itself over a year and a half, 2 years. So if nothing, don't rock the boat. Just leave them alone.
We use the new adjuvant Opdivo in some patients who have, based on the NHGM article, that showed 4 doses of Opdivo had dramatic response that you saw in the scans. What are your thoughts about that?
I have not been doing it outside a clinical trial. I guess my concern is that if you look at all the progression-free survival curves in the metastatic setting, there's a ton of patients that progress within a couple months of starting, and I'd hate to convert someone from curable disease to not curable disease by delaying their surgery.
Yeah, I would say that I would postulate that those patients probably wouldn't be cured anyway. But I would say that outside of the context of a clinical trial, it's really hard to do that. Although, again, some insurance companies will match lung cancer, immunotherapy, okay. So you may be able to get away with it. But outside of the context of a clinical trial, I think it's hard to do. Although I would say that that's going to be a thing. You know, if I were to put money, that's going to make it.
And I'm protected also because I have a clinical study, so I'm putting everybody on the study. Postulation, I mean, I don't know what the right answer is. I think there will be a biomarker that says these patients are going to be exquisitely sensitive. And if that's the case, then the question would be, should you give it before or should you give it after? I don't think we know. And we've all got these, I have small cell patients who are beyond 5 years on immunotherapy, different disease. But there are small cell patients who do extremely well. I think we're just not smart enough to know what that is. So in that neoadjuvant setting, whether you get it early or late, I don't think it's, my guess is I don't think it's going to make a difference.
With progression of disease on one checkpoint inhibitor, how about looking at another checkpoint inhibitor? For example, Opdivo followed by
Atezo.
Rituximab or Opdivo followed by Opdivo, or even looking at PD-1 versus PD-L1, like avelumab, Rituximab. What are your thoughts? Or do you know of any data?
Let's go this way.
Oh, so I can't quote any data talking about single agent followed by single agent. So I honestly don't know that.
They're molecules, after all, even though, as we all know, like Rituximab and Rituximab, they work differently in different epitopes and all that. The question is, could we potentially look into
So the other corollary to that is if somebody's failing, say, if somebody's failing Nivo after a year, would you consider adding IPI to it?
Yeah, so that's a question that I think comes up a little bit more often, and that the insurance companies are not that stupid, because again, you can't find that combination in any non-small cell guideline. So I think that outside of the context of clinical trial would be extremely hard to sell. And you know, the response rate of single agent immunotherapy in the second and beyond settings is what I quote to my patients between 10 and 20%, 15%. What would be the response rate of switching agents? I think it's going to be extremely low. I would say that you know, one of the mysteries of life is why pembrolizumab has so many positive trials, and that is not the case with other agents. And there are esoteric explanations, you know, they're just lucky, blah, blah, blah. But I actually saw one presentation at ESMO last year that someone did something really smart. There is no studies of it. But if you, and that just took obsessiveness to another level altogether. If you look at the package insert of antibodies, they have to do the following tests. They have to check for the development of anti-antibody antibodies. So that is in the package insert of each one of them. And you know which one has the lowest anti-antibody? Pembrolizumab. So the issue may be that you're making antibodies against the drug, and that's why they end up doing better. Again, you know, who knows? But that's actually an explanation that makes sense.
All right, wonderful. Thank you, panel, for the excellent answers to the questions. Then we'll move on to the next session.